now France child psychiatry in terms of diagnostic context, it is not really a very limited area. Of course, there are going to be some criteria in this regard, but we are going to conduct our roadmap in this sense. But we have to look at the situation in this sense. But in the practical situation, the things change. You know that. Because there are so different symptoms, and there's a variable symptom cluster in this sense as well. And this is making us. This is really making the situation work difficult for us, and we have been experiencing some issues in this sense. No matter what, we have to look at the issue in a certain. From a certain aspect, and we have to have a certain skill for this. So because rather than variables, they are asking us about the projections. What's going to happen with this child? So this is one of the questions that makes the situation most difficult for us. The question of what is going to be with this child. This is a really hard question for us. Your answer to this question is really important in this sense, because after 10 years, 20 years, they can find you and tell you that, Professor, you told us that it's going to be like this, but it didn't happen. Once I took such a ridiculous email. It was saying that when I was 6 years old, you told that I had a learning issue, but now I'm studying in Boğaziçi University. But what kind of a physician you are, and you can say that that I had some learning issues, and you see that you can be held accountable before someone when you say something. Of course, we didn't study. We cannot say that a person can study in Boğaziçi University or not, because you know that there are some issues about the phrases, expressions of the families, because they choose what you say. So you have to choose what you are telling to these people. So in this sense, one of the forcing issues of this area is about growing deficiencies. For instance, in OPEC, in terms of hyperactivity, autism disorder, and there are some transitions in this area. Of course, there are some questions in this sense. Maybe you cannot decide what is going to happen with this child. It may be autism spectrum, and there may be some development improvement in this sense, and it may turn into a hyperactivity issue. But in summary, I can say that we have a difficult job in front of us, and we can explain the situation really easily. While we are talking about neurodevelopment, when we can have some problem in terms of defining the development of this child. In terms of settled issues, the situation can change in any second. The symptoms may vary in any seconds, and in any second, there may be some symptoms that may worsen the quality of life very easily. So for today is critical in our polyclinic, for instance, in terms of the cases that we see in our clinics, what we are having some problems. Because when we are talking about the mood problems, mood disorders, regarding the diagnosis of mood disorder in children, they may be some different approaches in this sense. Of course, in terms of in terms of last DSM, there are some exclamations, but there may be some different changes in this sense. So why we are having difficulties, I would like to talk about these issues first of all. Then, regarding case, how can we make a diagnosis or not? I will talk about this. So why the issue is difficult for us? I'm going to talk about this and why we are having difficulties in this. And I'm going to talk about in these issues now.
So, clinically, what are the problems that are challenging us? I would like to elaborate on this because, as you all know, you utilize the technology very well and you can easily access the knowledge and you can use them. But however, organizing these information, knowledge, and when we confront with the patient, in order to know what to do with the patient, these exchanges are really important in this respect. So first of all, the first thing is that in a case of mood disorder in children, compared to the adults, it actually shows itself, it presents itself in another way. So I would like to elaborate on this. So the diagnosing process are not very easy. Of course, there are certain criteria and skills that we are using. However, here we are confronting rather a complex case situation here. And another issue is that, a subject is that in the adult psychiatry, there is a specific and clear presentation. And actually, the patients present themselves with the mood disorders, with their effect, with the way they speak, and as well as the companions who take that patient to the clinic for the examination, in terms of the explanations provided by the companions, so the diagnosis is clear. Perhaps there might be some conditions where we would be challenged for diagnosing. However, important number of the children, though, the verbalization is not very well, though, and just rarely the patients or the children with good cognition, we hear from them, which would enable us to make the diagnosis, and they can easily articulate their and verbalize their emotions, and even in early age, they also tell their parents that they require them to be taken to the physician because that they feel themselves depressed or have problems. But the way that they transfer or they verbalize their problems, it's rather than verbalization, it's rather with the behaviors. And the most important of them is in the childhood depression, is depressive mood that is we're talking about. And this is, we see the irritable mood. So the irritable children take our attention. They drove their attention, and in their games, for example, in their playing with the objects, they go for certain themes. And on the other hand, there's a psychosomatic type of features, and especially in the younger patients, for example, nausea or pain or the gastric pain and some skin problems, they come up with as if presenting the symptoms in the outside or on the body. So there's also another case, and this is about in normal development, there might be some other differences. Perhaps are these the developmental problems, or it's a psychopathology? And you also have some difficulty in understanding. Yeah, of course, the patient or the child would be considered to be naughty, for example, or we can consider the patient or the child to be normal. However, this child was very well, and he was behaving well, and then all of a sudden he has bad tempers. Well, whether this is a reaction within the natural development, or this is a mood disorder or a pathology of the mood. So the anxiety disorders, especially when there's an intense or very dense anxiety, some symptoms and manifestations can be evaluated differently. For example, the separation anxiety would feel the children a chaos them feel themselves in a chaos, and perhaps this irritability in the children, in this child, this anger, or this whether this is a call for another different type of mood disorder, and we have to examine this very well. And there are some atypical or unexpected, unusual expectations as well. So as I have just mentioned, whether do we see the depressive mood? Yes, there is a group of children with depressive mood. However, on the other side, there is the aggression, irritability, anger range. On the other side, there is this decrease of the academic performance relatively. And while the child is very successful in academic performance, and all of a sudden there comes up and socially drawing back or going introverted in this regard. And classically, once again, within our classification, it is different compared to the adults. This is a different type of symptom groups. And we always come across with that I inform, and I state this with sadness actually, perhaps the guides and as well as our psychologists, our colleagues probably would know it, but there is a statement saying that the children are doing such and such just because of trying to draw attention on themselves. And then, for example, there is a newborn, and the child, in order to draw the attention, then just shows the knife blade to me. So we are in such a case, in a situation that with the normal rage, and there is a group of parents which who cannot differentiate between the normal rage and the abnormal rage. For example, 6-year-old would take the knife and then would tell the mother, "I would kill you." And then the mother tells us, "Oh well, he's a bit frustrated," or and he does this from time to time. So it does not reflect that this is a normal type of complaint. So there is a kind of symptom type of blindness, and perhaps the reason for this is that just to minimize this scene or this picture, to defend and protect the child from stigmatization, not to have any kind of diagnosis made. And on the other side, just thinking that these would go and would extinguish and diminish in time. They don't care for that. And this includes all the psychopathologies. Between the abnormality and normality, there is a very fine line, but the cases on the other side of the line, to be accepting to be on the border, is not right, and even the professions would be included within this group as well. So for that reason, the perspective of the parents, as well as the teacher, as well as the guides, their perspective from time to time would certainly cause a delay in diagnosis. So, of course, there are certain comorbidities. So, comorbidity is now a usual thing because this is a developmental process, and neurodevelopmental pathologies would be accompanied by the other pathologies, and this is not very rare. So, and even there is the mood disorders with a spectrum, and there's also a big spectrum with anxiety disorders. These are all being seen together, and these are also confusing us. And another issue is that the same symptoms are seen in different psychopathologies as well. So when you say irritability, for example, there are 10. So we need to differentiate these pathologies. So for that reason, there is this concept of differentiative or differentiating approach. So for that reason, in terms of the symptoms, we have the problems of the challenge in diagnosis. So of course, all these diagnoses have been organized and designed for the adults, and there is no depression criteria for the children, and there is you would just apply this to the children and you would adjust them accordingly. And also, what is important, as I have just mentioned from at the beginning, we and our colleagues who have to see the patients in a very short period of time have to say something to the parents, and while saying or explaining so, they need to act rapidly. Sorry, I correct. They you actually have to keep up these pre-diagnosis on the agenda, and this would certainly facilitate your work because you can say, for example, to the family or the parents that whatever the diagnosis, if there is a problem of aggression in the child, there is a problem of aggression, and this child is experiencing aggression, and we have to plan the treatment accordingly for the aggression. And in time, we will have clarification in mind as the time goes by. This would be verbalized and articulated to the parents, and whatever is there. And then every time you see and the parents do not tell about all complaints all of a sudden. One thing could be less important to the family, which would be very important for us. Just through a case now, how we shall tackle with the case and which perspective we should tackle with. And when we look from this perspective, it seems different, and on the other side, it is different as well. And at this point, we need to have a skill that we have to develop, and some interpretations should be done, and also we should carry out the follow-up as well. Now, one of the greatest problems of us is that any simple diagnostic case, if there is any simple diagnostic case, then we would refer and we would direct that part, and then we would be done with this. And yesterday, in another meeting, while I was presenting about autism, I also mentioned this. So, and it's not very hard to diagnose with the ADHD diagnosis. When you ask 4 or 5 questions, even though you make a very small, very short period of observation, it's not easy. It's not hard to diagnose the ADHD. Actually, you miss what is accompanying that situation. So, as the children's psychiatrist, okay, I have diagnosed this. Okay, this is the ADHD, and there are all the symptoms, manifestations. Okay, but what else? No, nothing. So this is what we observe is one of the greatest problems, and you're not supposed to diagnose and record it somewhere, but you have to keep the suspect in your mind, suspicion in your mind. Well, if we can, it's not the subject of today, but while it's just the time, I would like to mention this. There are many children who were started with the ADHD and started to be treated with this, but since the questions were not timely and were not the right questions, and also the parents did not pay attention to the children enough and sufficiently, the autism spectrum disorder is disregarded or ignored. And we're not talking about an autism case where we would diagnose the children when they are 2 or 3 years old, whether it is in the spectrum or out of the spectrum. This is something different. The Asperger disorder is about the abnormalities in terms of the social interactions of the child, the child who cannot make friends or in social environment would be who is challenged a lot, and even having issues with the parents, and also who is always focused on the issue that he's not understood well at school, so that exposed to bullying and the academic performance is bad, and also that the behaviors could not be classified by the teachers. So for that reason, the teachers could ask, how did you train this child? How did you train your child? So irrespectful, disrespectful would be the complaints by the teachers. And on the other side, it might be the possibility that the impulsive child could also behave disrespectfully to the teacher. But there is such a difference in between of them, in between. So this behavior would be so bizarre by the autistic children, for example, would be named that this would not have been done, how this could be done. So this is something for among the developmental disorders, hyperactivity disorder, mood disorders, mental retardation, and we're not challenged to define them because there are the clear symptoms. But according to the related to the accompanying comorbidities are something that we can diagnose, and we have challenges in diagnosing. And if there would be a problem in this, it means that we're not, if there is a problem, it means that we cannot plan the treatment well, and we cannot give the message in the right way to the parents. So especially related to the HDHD. So the child who would benefit from the treatment of drugs with the children with the ADHD, there would not be any development in the social skills development, as well as the other problems. You cannot provide explanation to the parents, and still you cannot also provide a solution. Just through a case that I have been following, I would like to tell about how we can understand the mood pathology in a patient, 12 years old girl, has got a twin as well, and also has got a 9-year-old sibling as well, and they are 3 sisters actually. When she came to me, she was studying in a special private school, and the socioeconomic cultural level of the family is quite high, and they are educated. And principally, if the child is an over certain age, then I consult with the child separately. And before I forget, in next Congress, related to the clinic interview, I would like to give a course on this. And related to clinical interviews, there are really severe problems in this. And of course, you have got limited time. I cannot mention this. You have to see the patients within 10 minutes, okay? But don't talk everything while the parents are with the child. And this is actually would certainly harm your profession as a physician. And as we would have time more, to the extent we can utilize our time. So I take the child separate and try to get the information directly. Not all the children would be able to give the information directly, but many of them is possible. And and the child and the girl said that I don't love my mother. I like risky things, and I'm very active. I become very angry, and especially I'm very angry with my mother. And what the parents told us, she's different, and she always says that what happens, it has to happen whatever she wishes, and if this doesn't happen, she would end up with the aggression fits, and then there is a verbal and as well as physical aggression, and then she would harm the surrounding, like the objects, so on and so forth, and continuously she causes problem within the family, and we're talking about such a structure. And the mother can be harmed in such a severe way. For example, beat it, and then you're spending a lot. Who are you if you are, if you, if the mother is devaluated and the father is made to be superior, and then the child says that you were grown in the shanty town, and as of the 5th or 6th years of age, in the and then when they develop, and then she starts despising her twin as well, and then she has such problems, and they have got a big company, and she says that I will be managing this company, and you cannot do this, and we're talking about an sixth grade child, sixth class child. I don't like the people who are in poverty, and she despises them, and she behaves the helpers at home, assistants at home as well, and then she also says that you will make me a killer. I will kill you even. She says to her mother. The interesting thing is that after having the discussion and the fight with the mother, and of course mother cannot stay calm, and why she should stay calm, of course, and then as I have just mentioned, and the mother says that the child is actually jealous of the twin, and then afterwards there are many words cited by the child, and there are really despising many words, and then she regrets, and then she apologizes, but after a while once again she repeats the behavior once again, and there's nothing changes, nothing changes, and just with a little problem in home, there comes up a problem, and then she has a shopping habit, and she's very in favor of big brands and very expensive brands, and she wants to have those brands, and if this does not happen, then she would cause a crisis, and she wants to be always with the friends, and she wants to come back late, and she has friends with other from another environment or a surrounding. She has a very high mentality level. There is the IQ more than 140. And she talks a lot, and she has a very good attitude in discussions. But there's a problem in shopping as well. She always make a comparison with the mother, and she wants to get the more expensive of the bag, and then she always exploits the father, and then the father sometimes provides this opportunity, sometimes not. And then let's talk about the twin. The twin is very calm, and then the twin is very peaceful, and she has got a certain surrounding. They're in the same school, and they're not together at school though. So she was diagnosed with the mood disorder as well as free learning disorder. And what does she have in her curriculum? So this was normal, but she doesn't like the principal's rules, and she acts as she likes, but she's successful at school. So for that reason, the teachers actually did not deal with the child in this respect, and so from time to time she had problems at school as well. And then the teacher tried to create a compliant environment for the child, and always she's always expressed and described as a hard child. And in the secondary school, of course, there was the increase in the number of the teachers, and then there was more conflicts with the teachers. And she is very, she's very intelligent, and she's at a school which is challenging, which is certainly she has a academically high school, and she's very ambitious. And if the, of course, a child or is successful in academic wise, then she would be tolerated in terms of her behaviors. And if she is not, of course, academically successful, she wouldn't be tolerated. So with the teachers, she starts experiencing problems, and then the teachers tell the parents that you better go to psychiatrist for this child. And then she rejects and objects to very simple things, and she finds the problems, the errors of the teacher, for example. And then they contact with the psychiatrist, and then a psychiatrist refer them to a child psychiatrist. And especially this happens within the family. This does not happen only within the family. When they go on vacation, for example, in an atmosphere where they would be enjoying the atmosphere, then they would start with the arguments, and the crises are caused by the child again. And when her wish is not met, for example, and this is the part I'm talking about, and our psychiatrist colleague sees the child and the session is long one, and then she and then she's diagnosed with ADHD, and then the parents do not reject this, and they start using the drug in the child. And within 1.5 and then 2 months, and then they see that the condition was worsening, and then they stop using the drug, and then they end up with the psychiatric treatment then afterwards. So now, this is a very simple mathematic logic. Let's say that you even see the child for 10 minutes. Please ask whether there's a diagnosis of psychiatric diagnosis in your family. And this is the most important question, and this would be referring you the most. So just very strangely, this question was not addressed. And there's an uncle and has got a diagnosis of bipolar, and just further beyond, perhaps there are some other diagnoses on the second axis. There is a great family company, and this uncle never worked, and married and has a spouse and with one child, and continuously receiving money from the family, and high amounts, of course, and he spends this money. And from time he is hospitalized, and sometimes he rejects the using the drugs, and a big crisis take place. In such a case where the uncle has got bipolar, actually, there is no need to be a psychiatrist to ask the question, wouldn't this be child have an ADHD, since the uncle has got bipolar, is diagnosed with bipolar, and shouldn't we ask this question? Now, let's now come to the point that, so if the parents or the families do not ask questions, our work would be easier. So I would say that the children's psychiatrists would have a easier work if we didn't have the questions from the family, and we would even see how more than 100 patients a day, because the families exhaust us. Sometimes they are unright, they are sometimes right, and then they would certainly harm or distort the compliance to the treatment, and they also expect a miracle from you. They distort the treatment, and then they read out the prospectus, and then they wouldn't use the drug, and they would ask for an alternative. And the other side, they would go visit the one physician, and then the other physician, so on and so forth. And then they would test you, and then related to you, some challenging things would be done, and just very mildly, they would ask you questions and then expect to have the answers for this. And this part is of course normal. We do not object to this. However, as the child psychiatrist, related to responding to these questions, we have got certain challenges. So you say, let's say that you have started the treatment with drug. So how much we shall use it? So give the answer. Doesn't matter. So anxiety, bipolar disorder, ADHD, and how much we would use it, and the tic disorder, for example. There's no specific answer to this. There are many things here, and we need to answer this and explain this as well. And case-based, only on case-based, we can talk about it. Whether it would be used for a long time. So at 3 years old, for example, whether this would be used a long time, a long life, we don't know. So the lifelong question, these are not abnormal questions, but they actually challenge these questions. So we have to answer this. So they ask about the diagnosis and whether this is an ADHD. So what we're going to be doing this. So with the treatment, the condition of the child worsened and then impaired. So how long would we last? Whether the child would take the drugs lifelong, and also more specific questions come up. More challenging questions, and with the answers that they get from us, they want to get the questions and organize their lives accordingly. This child has got and performs high performance, and he wants to be educated in high school, in abroad. Whether he's possible to be educated in abroad, whether we would come across with other things when he goes abroad. So such like in the child psychiatry practice, there are very specific points, questions that need to be addressed to us. So I've got such and such child, we do such and such, and then I will divorce. And what do you say? If I divorce, whether he would or she would worsen or would impair, or would it be better? We would change the country, and we're planning to change the country. We will move to Germany. How he or she will be affected? We will change whether we should change the class or the school, so on and so forth. As the clinicians, at the points where we are assured by 100%, we would certainly respond. So let's say that the child has got a problem with the teacher and has got always complaints about the teacher, and then teacher, as for managing the child, is not enough, and then you would certainly say that we shall change the teacher. But in the cases where you are completely assured and there is no answer to this child, whether this child would be able to be educated in abroad, we have seen for the first time, and the diagnosis would settle in mind, and then still in such radical questions, never don't give answers black and white, and because it will certainly hit you at the end of the day, because the family would tell you that you sent this child away or to abroad, and then our child has not been attending classes for 2 years in London, and he just wandered around. but it's not the same situation like in Turkey. And then he said that, okay, I'm done with the school and I have passed my classes, he said. So if we would give a message, there are such and such risks, and there are certain such and such conditions, then this would not be harmful that he or she goes abroad, but there are certain risks that would hinder the procedure, you would say. Otherwise, perhaps there's no legal responsibility. However, ethical-wise, you are accommodating a certain risk for these situations. So now, let me continue from this point onwards. So I think that my granddaughter wanted to show herself. So if we can just go back to the beginning. So related to the differentiating diagnosis through the case one, the child psychiatry, the most urgent and the most important symptom is aggression. It's clear. And of course, suicidal intentions, or just apart from these, of course, exceptions. So the self-harming, for example, if we just keep them outside or exclude them, the most urgent one is the aggression fit, or the seizure. So if you cannot live with a child who would be in continuous aggression, and of course you can live with that child, but your quality of life would certainly drop. So we need to define the aggression very well, and we need to define very well where it comes from, and then the severity and the type should be well known. In the place where there is aggression, there would not be peace at home, neither at school. So for that reason, there's this diagnosis of ADHD. There are all symptoms of this. According to what we're diagnosing? According to the classification systems. The ADHD classification criteria related to aggression, is there any symptom for this? Is there any indication for this? No. So there is no aggression in impulsivity. So impatience, not being able to wait for a long time, so on and so forth. So just looking into this, symptom, we cannot say that the child has got the ADHD. So here we have to elaborate on this. What are the reasons that create the aggression within the indentation? What are this is the real reason, or it is just because of the very simple reasons there comes out to be an aggression? We need to understand this first. So the aggression coming up because of very simple reasons. For example, at breakfast, why you didn't make me a toast, and then continues in a very ridiculous way. Today there is rain. Don't meet with your colleagues or friends. If you say so, then there comes up another crisis. So even with a very simple hindrance, if there comes up an aggression, we have to keep this separate. This is actually a very great symptom. Secondly, so there is a great despising the mother and the twin sister. So there would be the conflict between the mother and the daughter. And it happens in every home. And also the father and son conflict. And there is such This is not scientific, but just depending on the observation, of course. But there's a certain rate for this. So it is not that despising the person opposite continuously. It is not about the adolescence. So devaluating the mother, you would make me a killer of a mother. So these are really big insults. So in the second session, the mother cried so hard, and then she said, "What did I do to this child?" And then she doesn't do anything, and then because there is nothing with the mother, because there's the other twin. We have to pay attendance and this grandiose type of behavior. So the ones who are providing care, insulting these people, these are really problematic. We have to place this somewhere. This is not something to be disregarded. This is really an important symptom as well. So in recent times, especially, there is an increase in the shopping habits. So you would tell, actually, the family has got a very, the economic condition of the family is good, so that it's possible that she can shop, but not that much, actually. So this, what is this impulsive shopping wish? What are the risky things that she articulates? What does it mean that she doesn't fear anything? And we need to scrape this and scrutinize this. These are not something to be explained with ADHD. And from this perspective, and another important point is that, and it's about that apologizing from the mother. So in the following interviews, so for that reason, this she never reflected this to me. This is said, articulated by the mother, and this grandiose structure, the apologizing. She thinks that this is some kind of a behavior that is to be despised. So for that reason, she never shared this with me. But in the interviews, she always mentioned that she is always behaving unjustful to her, and the father is very competent, very skillful. Just oppositely, the mother is so she's lacking skills and she's not working. However, there are certain there's the foundation of the company. She works there, but she's not a mother who spends her whole life socially at home. She also has got certain effort, but despite this, she goes for the mother. But the fundamental thing is that she's in the 6th class, and she says that I will be studying at a board school in London, and then after I'm done, I will go to the States, and then I will be educated in such and such school in the business, and then I will be managing everything in the company. I will tell my father to retire, and then these are the things that she thinks about while she's in the 6th grade, 6th class. So, but in the meanwhile, it happens what she tells about in a very bizarre way. So, colleagues, I will just skip depression, because depression, this way or the other, although even though it's not clear, the depressive mood as it is in the adults, with its the time onset time, and as well as with its circularity, and also some we're starting with after some reactive incidents, and this bad feeling, and sometimes it expresses the anxiety, presents the anxiety, so it can easily be differentiated. So in the adolescents and also in children, the depressive mood, we see that irritable mood is rather prominent. So the difference in neurodevelopmental disorders. In neurodevelopmental disorders, you experience this in all the processes. But if there's a mood disorder, if there's a depressive process, it is said that this child has been in this period since 3 months. So neurodevelopmental moods, and to be differentiated these mood disorders, there are certain criteria that we take into consideration. One of them is the onset time. So neurodevelopmental disorders, even though in criteria it is stated that it starts at 10, 12, so on and so forth, there are certain delayed diagnoses, especially the insurance companies do not accept the diagnosis, so they are delayed. For example, you have seen such a diagnosis. Everything is fine until 10 years of age, and then all of a sudden the child has ADHD at 10. This is not possible. At least there would be very unclear symptoms. Perhaps there would be hyperactivity or attention deficits, and this would not be understood well, and there is no problem with behavior as well. But in the 5th or 6th class, they fall because that deficit, this attention is not enough. So for that reason, a pathology that was present in the past now is uncovered. However, depression is not something to be skipped and overlooked. So from our perspective, what we can say is that in child psychiatry, irritability the most problematic mood disorder is the disruptive mood dysregulation disorder. DMDD is called. It's rather very hard to shorten it in Turkish. So for that is we just call it DMDD. So as I have just mentioned, such a diagnosis, as I have just mentioned, it's with a chronic irritability. And cannot be explained with neurodevelopmental pathology in children. So in such a child, this irritability is not normal. If it says so, then it's a process that this child is diagnosed with bipolarity. And they do not respond to the stimulant treatment, and there's a mixed condition, and this is a mood disorder actually. So is there such a mood disorder because the number is so high? This is not very realistic. But on the other side, mood disorder means equals to episodic. It should take time. It should happen within a certain time. We're talking about a chronic thing, not attacks. It should attenuate in some time, and then so it has got more than 365 cycles. So in order to hinder this, prevent this, we see that there is a mood disorder definition. Actually, the problem is this. Many clinical psychopathology would disrupt this diagnosis, and the separation anxiety might be dysregulated, And in autism spectrum disorder, the regulation can be distorted. However, the main problem is that, so it's clear that there is a big problem, that there is a problem in the child with a mood disorder. But now there is, the scientists divided into two. One group says that this is an obliged and forced time diagnosis or definition, and we need to name it somehow. If this is depression, no, there is no other symptoms of depression, so irritability and the mood disorder. So for that reason, and I see such cases clinically, but if you call these cases ADHD, then it means that you haven't seen such a case. So there is a very simple thing here. So I say that to be understood clinically. There's a disorder of opposition disorder. So there's a pathology likewise, just on top of this, 3 or 4 times weekly. I'm not discussing how many times it would happen. Clinic is much important than the classification systems. So in a way that would disturb the family if there is a clinical irritability underneath, but just because of very, very simple reasons, there's a case group where there's an aggression, a high aggression, and they don't have other mood disorder symptoms. They're not depressive. They do not have anxiety, and also they do not have the other depression symptoms or manic, for example, manic symptoms during the hypomanic or manic. There should be other symptoms, manifestations, but they are lacking as well. So chronic, if there's no manic episode or a chronic aggression, then this would be DMDD. Perhaps they may call something the other day, but there is such a case. This is not something new. It was diagnosed, it was defined in the DSM-5, but just far before there was there was DMDD, but so severe mood disorder, for example, clinically. Why this group is like, was this explained already? Some of the other explanations. So what is the problem here? During the adults, they evolve to something. So this intermediary period is developmental. So some of them become depressive. As per some studies, they become depressive, but according to some studies, they become bipolar. In some studies, they do not come or end up with anything. So I would like to talk about my own clinical experience, that the challenge, the difficulties that I will shortly end and terminate. And there is such a group here. If these children, in these children, if you can explain the diagnosis and the disease well, if you can develop the management skills, and among this, they need to get a psychotherapy regularly, whether you do it or another person, but if you can manage or develop the crisis management skills, and if you can develop the skills for not causing the crisis, then you can deal with the situation easily. Otherwise, we would prescribe the medicine or drugs, but if this doesn't happen, nothing would happen. So I have such a case likewise in my profession. This is the youngest child that I hospitalized, 6 years old. At 6 years age, because of aggression seizures, And fifth, they couldn't keep the child at home. I treated with medicine, so also when I sent for the therapeutic sessions, but there's an anxious mother at home. She responds to everything very too much, and she has got high anxiety, and he would or she would harm herself. And then do you accept to be hospitalized? Yes. And then our colleagues ask what you would do. Would we prescribe medicine? No, because we have already prescribed and you gave what was required. Just for 4 days, we took the child away from the mother. I don't want the child to have the mother with him, and just father would visit the child for 4 days. Afterwards, after 4 days, we discharged the child, and still I follow this child. After 4 days with the zero treatment, he was discharged, and the parent attended the psychotherapies. I did not prescribe any medicine because it didn't help with the medicine. Now I think it's in the 3rd year and we have zero problems, but there are small crises though at home, but still managed. And the management of the parents is very important. And in the meanwhile, of course, it's very valuable that there's a good management done at school too. And the schools against these errors done committed by the children, they sentence the children so that they become more irritable, and then the school should be managed well as well. Of course, this is a different subject. To which extent they can be managed, it's a question mark. And in the MDD, there is no manic episode. So when you say when you ask when there is no DMDD, if there's a manic episode, otherwise this would be called a manic disorder, depression, including depression in the spectrum. If it is not explained with only that disease, then it can be explained with DMDD. Of course, DMDD, the opposition disorder, can also happen. So DMDD is the higher version of the opposition dysregulation. So when we talk about this child once again, we should be talking about hypomanic episode or depression episode. And also there should be elevated mood, wouldn't be required, but grandiosity, impulsiveness, risky behaviors, hypersexuality, and the sleep, lack of sleep, and lack of language communication. So for example, there's grandiosity. So in such a child, clinical interviews and information gathered from the teachers and scales and developmental analysis to be good. And the most important thing is here long-term observation follow-up. And in the long term, whether we can call it a bipolar. So this child with a bipolar uncle, you cannot tell this patient. So the family asks, what is this diagnosis? DMDD, ADHD. So not the bipolar. No, not yet. But since there is a family risk, then since he has got the mood disorder, whether there could be a bipolar diagnosis. For that reason, we would follow this child. So the summary is that we need to evaluate the mood disorders as a whole. When we have a piece of that whole, then we should not make the interpretation through this single part. We should think comprehensively, and we should give the message accordingly. When we come to the story of this child, because of this aggression fits, because that he didn't benefit from the methylphenidate, and then I started using the risperidone, and then it was 0.50, and my objective is to decrease the aggression fits so that we could there could be management of the crisis at home. And then I refer the patient to a therapist, and then the mother is anxious as well, and she is very challenged. And then she started to continue with the treatment as well. And then he didn't object to taking the drugs, and then they asked whether she could be educated in London, and then said, okay, is there a risk, and then whether she should use the medicine, and then you should follow and observe the child, and then the medical treatment is now over, and now she is continuing with the university education in the States. Thank you very much for